Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Welcome back to the Innovation Accelerator Podcast Book Club. This is Steve Ambrose. We don't have a broken healthcare system. It's a perfect system. Consumerism and free market approaches, well, they largely can't work in healthcare today. Many insurers play make-believe in their claims on value-based reimbursement. Fixing the system? It's talk that's largely bunk, and it's mostly a way to deflect pressure. We need a definite end to employer-based health insurance, and let's incentivize organ donations and end-of-life choices through financial remuneration back to patients. Those are the thoughts of our guest today, and he's put them forth with no apologies or regrets. Why? Well, he wants to get leaders, especially in the payer industry, to, quote, fuck shit up in our health system to get genuine transformation. And Jeb Dunkelberger is a seasoned and well-known CEO and thought leader who pulls no punches in his most recent book, Rich and Dying, An Insider Calls Bullshit on America's Healthcare Economy. Jeb's career has spanned an executive role in Fortune 5 companies. He's built some of Silicon Valley's most disruptive healthcare startups, and he has healthcare-related degrees from Virginia Tech, London School of Economics, London School of Hygiene and Tropical Medicine, Cornell, and the University of Pennsylvania. Jeb, thanks so much for being here. Welcome to the show.
Steve, thank you so much for having me.
Well, in my 30 plus years across healthcare, I've never run into a book that's this raw and transparent. And your book is broken down into 3 sections: Perfectly Stuck, The Failure of Self-Reform, and Starting Over. And Jeb, I'm not going to pull any punches in our conversation here. We are jumping into the tall grass, and we're going to talk about your thoughts, the takeaways from the books, and the action steps needed to change our healthcare system. But first, I'd like you to tell our audience a bit about your journey in healthcare up to this point.
Sure. Yeah. Well, like many people that work in healthcare, I was introduced to it through unfortunate circumstances within my own family, losing my stepmom at a fairly young age. But the thing that was most critical during that was after she passed away, looking at the financial devastation that was felt by my entire family. And it is unfortunate circumstances, but it made me look at the entire system in quite a different way. Because there's at no point throughout her clinical journey did I ever feel like providers were abusing the service, like they were manipulating decisions or guiding us in the wrong direction. That being said, to be sitting there with a multi-million-dollar bill after 6 years of fighting brain cancer, you can't help but think maybe there's something that needs to change. So from there, went on into school, really focused on the healthcare economics side of the equation. Actually ended up going to grad school in London School of Economics, where I really focused on healthcare finance and policy. And then from there, I worked at Ernst & Young and really focused on the Affordable Care Act and how that affected both payers and providers. And then after that, I worked at McKesson, working with the ACOs across the country. That led me into a joint venture with Blue Cross Blue Shield, which was fortunate as that led me into my next job at Highmark, which was the only Blue Cross Blue Shield plan that is also an integrated delivery and financing system based out of Pittsburgh. And if you ever want to look for just some progressive folks that are working within the Blue Cross Blue Shield family, look no further than Highmark. And then from there, I actually went out to Silicon Valley. I worked with some really progressive organizations, one focused in renal care called Cricket Health, which is now Interwell, and then a robotic automation company called Notable. And then eventually moved on to lead a provider-sponsored health plan in Northern California called Sutter Health Aetna, and competed, in a market with blue on blue competition, with Anthem and Blue Shield of California, as well as being in the backyard of Kaiser Permanente. So I feel like I got some scars and stripes, and I learned quite a bit there. And then most recently, I moved to South Carolina with my wife. She's a trauma surgeon. So, we always kind of go back and forth about who's more relevant in the equation. And the answer is always her. As you come to think about, it forces you to think day in, day out, what are we doing and how do we prioritize folks like her and the career that she serves in, and think differently about the role of an insurance executive, like the role that I sit in. So I currently work with Prisma Health, which is the largest provider in the state of South Carolina, the second largest employer in the state of South Carolina. And it's a really interesting state to work in. It's a state that's growing quickly, but it's a state that unfortunately has also been stuck without as much innovation as maybe some of the Northeast or Western states have been accustomed to. So there's definitely a lot of proverbial low-hanging fruit here. And that's one of the reasons why we moved.
Well, thanks, Jeb, for that. And I appreciate you bringing us up to speed. And let's jump right on in. First, why did you write this book?
Yeah, I think that when I sat down, first off, I'm just going to call it the most obvious thing, which was I wrote it during COVID. So I think while we were all sitting there at home with a lot more time on our hands, I felt myself just continuously going through these different thoughts around, is it worthwhile to put out a rallying cry? And I was sitting there on LinkedIn and I'd think about maybe I should write a post, and I'd reach out to some folks and I'd find out that they feel somewhat similar. What was more interesting is that finding people that were 5, 10, 20 years into their career that agreed with a lot of the sentiment that I shared, but didn't feel like it was appropriate to actually come out and state it so bluntly. And I think that largely has to do with just job security, right? To come out and kind of bite the proverbial hand that feeds you, I think it's a scary thing. That being said, I was picking up on this cultural shift, which is the fact that 50% of the working economy is millennial or younger. I mean, these are folks that are used to disruption. They're used to asking why. And so as I began to kind of go through my reading list, I was about a year into it during COVID. I said, I have not found a book yet that I feel like is truly honest. I always feel like it's polishing someone else's shoe. We're always protecting some sacred animal. We never want to call the baby ugly, whatever catchphrase you want to use. And so maybe I'll take a shot at this. Now, one of the scariest things for me is that I'm still kind of in my mid-career point. There's a lot of things that I don't know. And as I was researching for this book, it actually confirmed the fact that as you learn more, you kind of figure out, well, there's even more that I don't know. So it was a little bit of a gut check in terms of saying, do I really want to put this into publication? Do I really want to have other people read my thoughts? But what was the most energizing thing is that as I began to pass out this transcript before I put it to publication, the amount of people that came back to me and just said, thank you. Thanks for just putting out thoughts that we've had for some time. And I even went so far as to ask friends for excerpts and examples and their own opinions, and I incorporated it into this. So it was an amazing opportunity to get all the thoughts down on paper. But more importantly than that, I feel like these types of books only come out when people are retired. You mentioned that at the beginning of our conversation, that you don't typically see these books until someone's retired after 30, 40 years of experience. But the problem with that is, when you're retired, what are you going to do with all that information? Sit on a few boards, try to direct a little bit of an agenda or a policy reform? For me, I said, why don't we find more folks that are actually in the foxhole, the trenches today? Read this book, become aligned, feel that call to action, that rallying cry, and then leave yourself another 10, 15, 20 years, God willing, to actually see some of these changes into the industry. And so for me, it was all about kind of finding common allies that still have a good decade or two left that actually want to see some of these changes into fruition.
Yeah, you bring up a really good point there, and thanks for that. And that is that a lot of people sit on their thoughts, particularly people that can make change happen. And so I really do appreciate you bringing that up. And, many people who seek healthcare change believe that we need to have more free market forces and greater injection of consumerism coming in. But you believe that our health system isn't capable of operating in a free market system, and that I believe I have this right, that consumerism doesn't actually exist in healthcare, at least in the economic sense of the term. I'd like you to maybe explain a little bit more about your feelings there, your thoughts there, and what led you to that.
Okay, well, I can tell you right now, as an economist, I definitely believe in the efficacy and the efficiency of a free market. I want to make sure that it is perfectly clear. I'm not contesting the realities of what a free market can bring to certain sectors. Unfortunately, free market economics have some critical ingredients to be successful. For one, you definitely need symmetry of information. I always liken that to a Carfax report. When you're actually going in to buy a car, you have the ability to look up if you're buying a lemon or a brand new car, right? The ability to actually also understand, do I need this car, right? You tell me that I need this Lamborghini, I can tell you emphatically, I do not need this Lamborghini. That being said, if a doctor tells me you need an MRI, your brain is bleeding, I have no ability to fact check that. I have to trust in that process, right? Also, another necessary ingredient within free market economics is the ability to have price transparency. And although we've taken a major step forward in this country with some of the federal regulations and the transparency laws, I think most consumers can admit that it is not easy to navigate those machine readable documents today, nor are many of these experiences or interventions shoppable. And so even when you find out that you need to have some sort of intervention, the referral lanes, the management, the scheduling, all of that is not an Amazon-like experience. And so as you think about it, you go, well, there's no price transparency. There's no symmetry of information. Unfortunately, there's also no elasticity of demand, right? And so really what that's about is as price increases, you want to see demand decrease in a free market, right? That's how the consumers or the buyers and the suppliers keep each other in check. But as we all know, healthcare costs continue to go up. And if you tell me that I need an MRI because my brain is bleeding, you can rest assured that wherever it is, whatever it costs, I'm most likely going to say, yes, I need that. And unfortunately, the folks that say, no, I do not need that, usually are preventing needed interventions that are earlier within that pathway, which obviously then leads to higher cost later interventions. And so as you begin to then think about that, you say, well, what's the last major ingredient of a free market economic model? And that is ease of entry and exit into a market, right? So if I'm thinking about that car example again, I could set up a dealership right across the street to compete with another one with some little permits and regulation. I can get through that with a little bit of capital. I can get that off the ground. That being said, to set up a hospital, to set up a physician's clinic, the amount of training, experience, credentialing, board examinations. I mean, we are talking about a decade plus of just experience and work, not to mention the capital. And then if you're living in a state like South Carolina that has certain certificate of need laws, you have filings, you have politics, all getting involved in that. So again, free market economics is great in theory, and I completely agree with it as an efficient model in most sectors. But within healthcare, the inability to have elasticity of demand, the asymmetry of information, not having price transparency, and the ease of exit and entry into a market kind of prohibit that. And so all of those things combined for me to say free market econ really doesn't apply to healthcare. And then that just really ties into consumerism. You know, I even go so far as to say that within consumerism, folks think that they have a choice, which provider they go to, how much they're going to pay for a certain service, what insurance product they select. But the reality is for over 140 million Americans that are receiving their insurance through their employer, I liken it to giving a child a choice between bananas or apples at dinner time, right? The actual choices that were made by the parents long before that moment when they was going to the grocery store and they selected, are we even going to buy fruits to begin with? If we are, which fruits will we purchase? And then what do we put in front of our toddler to then select apples or bananas? I don't mean to be so simplistic, but at the same time, I think it's an important point that when we're sitting there saying, oh, I would like this Aetna versus the Cigna product, there's a lot of decisions that were made before that. Not to mention that the network within that product is then going to define who's in network, out of network, low cost, high cost, $0 copay, $50 copay. And so your choices, or what we call the paternalistic choice architecture, is largely governed by folks that are not you as an individual. And so as we romanticize the level of consumerism, I can't help but kind of bring reality back into the picture to say, yes, it sounds great, but in reality, I do not think that it actually exists.
And I'm just want to add to that last answer you had. Isn't there something in your book that you mentioned about specific to picking insurance plans or something along those lines, that 75 choices, maybe I have the number wrong, but 75 choices are already made for you before
Yeah.
you make the first choice? Something like that?
Oh, yeah, great memory. Yeah. So what we did is I sat down with a few insurance brokers and I kind of went all the way to the very beginning of the process. And I said, how many decisions have to be made before the individual actually selects which product? And you're right. Yeah, it was north of 75 decision points that are made before the actual individual says, I would like that Aetna PPO or HMO product, or I would like that Blue Cross Blue Shield POS product. And so again, the folks that think that they are playing an active role in their decision making, you certainly are, but the decisions are confined to a very small box that were predicated by a number of very large decisions before that.
So you spoke about price transparency, and as we know, price transparency was created to drive greater awareness to patients, promote more competition. But you state that it doesn't work in healthcare. And I want to attach onto that I'm sure we both know, and many of our listeners know. I mean, we have a real crisis in this country around affordability for healthcare services, coverage, and certainly prescription medication. So if price transparency is not the way for change, is there any way that you see, Jeb, to halt or even lower the prices of care and coverage for individuals and even employers?
Yeah. So first off, I think that price transparency is a very noble and necessary regulation that we are putting forward and that we're watching as hospitals and providers create more transparency around their pricing structure. I think the belief that individuals or consumers are going to pick up that data and then actively make new choices based upon that, it's just not happening in the large droves or a majority of the population, like I think a lot of the policymakers may have believed that to be. I actually think that the more useful area that we see is brokers and consultants using this to define new networks within their self-funded employer clients. And we also see insurance carriers using it as a way to compare how a hospital is setting its rates from one payer to the next. So does it create competition? Absolutely. Does it create more honest conversations? Absolutely. And are those noble and the right things to do? Absolutely. I have no problem with any of that. That being said, for the folks that think that this is just the only piece of the equation that we need to press on, and that somehow is then going to unlock a free market economy where providers will compete actively for consumers, I think it's just important to remind folks about how these decisions are made. So many decisions within the clinical journey for an individual are made by the clinician. And so the clinician is governed by other incentives outside of the view of that consumer. It's amazing how many providers also have no idea what price transparency even is. And if you look within their clinical workflow, there are a few things that are guiding them to lower cost or higher cost sites. The things that do govern them are things like the relative value units or RVUs that are tied to their compensation and their bonus. And they are acutely aware of what drives an RVU up or down. And so that is the type of area that I like to focus on for the causal pathway of changing something. Unfortunately, we also find that a lot of patients don't know the cost of a service until after the fact. And again, there's new regulation coming out that is already, being implemented. And then we are seeing the after effect of that through no surprise billing. And again, this is the right step. This is exactly what consumers deserve. That being said, how many consumers are changing the direction or the course of their clinical journey based upon that information? I think that's what we need to focus on, because there's a reason why not so many folks are actually in that area. And when I say in that area, I mean using that data in an effective way. So this is spawning a whole new arena of actors that we've seen kind of coming up, the care navigators, the benefit navigators. Use examples like Accolade or Quantum for companies that you can look at for that exact example. And again, what are they doing? They are creating value. But is the value real? Yes, in theory, because you're comparing a higher cost journey of care versus a lower cost journey of care. But the problem that I have with that is that we're creating artificial value, right? That's like me sitting there and saying, okay, I'm going to race to the end of the driveway and my wife's going to walk to the end of the driveway. And I want money if I can speed past her and sprint to that end of that driveway. Did I really do something special there? Or did I just measure myself against the highly inefficient process of getting to the end of the driveway, which is walking? And so parts of me feel compelled by the steps that we're taking, but also parts of me are still dubious about the fact that these pieces need to interlock and come together. Now, changing healthcare and the tectonic plates that need to shift here, I mean, as many folks know, the size of the U.S. healthcare system is the equivalent to, I think, 2.5 GDPs of Russia, right? I mean, you were talking about a massive sector. So again, these are the right steps. But that being said, I hesitate to applaud these minor milestones that still require large codification and linkages between the use cases and actually getting it to the end user in a time and at a point where they can actually change the direction of their care journey.
You know, it's interesting, and I appreciate you bringing up the size of the market. We're going to get into that in a little bit as well. But so as a whole, when we talk about the pricing today in healthcare, and one of the things I've found, I'll just share, is in my interviews with leaders in the past, Jeb, when I start asking about price, a lot of times the conversation flips to cost. It's almost like there's a little shuffle that goes on there. And I'm not sure if it's deflective, I'm not sure what it is, but it doesn't seem to stay on price. So I guess just to round out this one question, do you ever see a time where the pricing levels that we're seeing today in care services and in care coverage are ever going to come down or ever going to be largely, let's say, more affordable than they are today?
I have to say yes, because at the end of the day, if you're going to work in U.S. healthcare, a part of you has to be an eternal, external optimist, right? You got to believe that everything that we're working on is at some point in the future going to lead to a lower cost of care, right? And when I say lower cost of care, I'm not talking about absolute dollar amounts, I'm talking about percentage of the GDP, percentage of people's take-home pay. You have to believe that. If you don't believe that, then I have to ask, why are you even part of this, right? You're part of the problem then. We have to fix that. That being said, in order to get there, I think we have to be realistic about some of the variables that I see as fixed. That your largest employers in any state are a hospital, an insurance company, or Walmart. I mean, that's pretty much true for every single state. And so to reduce the cost of care, if you're just going to take it off the provider side and not cut anywhere else, I think you have to be mindful of the fact that we're already facing a physician shortage, a nursing shortage. We have massive issues in this country in terms of access to care. It's only going to get worse because the lines of business that typically subsidize Medicare, Medicaid, and the uninsured are the commercial lines of business. The percentage of the population that is of the commercial working age is dwindling. It's getting smaller year over year compared to the percentage of the population that is moving on to government lines of business. And so if hospitals and providers say that they just about break even or maybe even lose, and here I am bringing up cost, where they actually lose money on those government funded lines of business and they can't cross subsidize onto the commercial line of business or the employer, the question becomes, where do you go? Right. And I think that folks have pointed at value-based reimbursement as kind of the avenue to focus on in terms of getting that higher quality, lower cost outcome that we're all kind of chasing after. But we have to solve the equation for the health system. You know, I spent a lot of my career focused on primary care doctors working within Medicare shared savings programs and different forms of ACOs and PCMHs. And at the end of the day, that's great. And that's valuable, but that's only 5 to 15% of the total cost of care. The plurality of the dollars are going to sit within the health system to the tune of anywhere from 45 to 65%. And so we have to come up with economic models that allow the providers to remain financially solvent. Now, the current recession or pseudo recession that we're entering into, I think is going to put a massive damper on our health systems across the country. But as they come out of that, they're going to be leaner operations. That is a good thing. The question is, how do they become solvent within these value-based arrangements that we all agree are the philosophical direction that we want to be on? And so, yes, I do believe there is a future, but it requires us to solve for the largest piece of the equation, which is the health system. Although the primary care doctors and specialists and ambulatory sites of care are important ingredients in an efficient and lower cost future, we still have to figure out, what do you do with all the sunk cost that sits within the facilities? What do you do with all the professionals that are employed by these facilities? These are the largest employers in some of our local communities. So you can't simply say we're going to wash away 20% of your top line revenue. Figure it out. It has a macroeconomic ripple effect that we also have to solve for. So yes, I believe there's a future, but at the same time, it's a difficult one because it's going to require health system leaders to say, I'm okay if my top line revenue decreases as long as my margin is predictable, solvent, and potentially even increases in this new model of care.
Yeah, and of course we're seeing that now. I believe for the last 9 or 10 months now, we're seeing those operating margins just staying more narrow than they've been for many, many years. So it really is quite a challenge. We talked about free markets and consumerism and your thoughts on that. You also are not a big believer in the big government approach to healthcare. And I think that's safe to say. And two things I'd like to share, with our audience is first, your thoughts on the guiding principles in a big government approach, and maybe why those principles are keeping healthcare from being less successful. And then also, if you could chat after that, Jeb, a little bit about what you're seeing with the politicization of healthcare and how we're moving, more into that, more away from the science and facts and more into the politicizing of healthcare today.
Sure. Yeah. So first things first, when it comes to big government or small government, I just think that as you look at examples like how this country dealt with COVID-19, I firmly believe that is a dangerous recipe if you think that the government and the government alone is going to be the entity that solves the issues that we're dealing with. That's not to say that I'm not democratic or liberal when it comes to certain policies around healthcare access or affordability. That's certainly not the case whatsoever. That being said, what I believe in is I do believe that healthcare is local. And I believe that it requires a number of local change agents. And that's just not the insurance company in the hospital. That's the 80% of what determines our health, which is the social side of it, right? It's the housing, it's the education, it's the labor. All of these things are tied to local agents of change. It is impossible for the federal government to understand how to implement these types of programs at a local level. So you can set guardrails for sure, but at the same time, you need to allow local states to really drive this forward. Now, where it gets to be a little precarious, I think, is when you look at programs like Medicaid, where you have a local small state implementation process, but you have a federally funded program where about 80% of all the dollars of Medicaid are federally funded. So here you have a big government idea with small government implementation. That to me feels dangerous. And we're seeing that right now. We see states that have expanded Medicaid versus states that haven't, and the differing effects of that. In terms of the politicalization of healthcare, I don't think that healthcare is immune or different to any other area of our social life and sectors that we work within. We are finding that there is polarization across the spectrum, right? And I think that what we are, unfortunately, as a society becoming too accustomed to is the 160 character tweet, the less than 2-minute video, and we are becoming enraptured with sound bites and not taking time to actually develop the content, understand the message, and develop our own opinions. We often would rather retweet or reply to something than think of the idea on our own. And this is going to be something that for the younger generations are going to continue to plague us. That being said, what a beautiful moment for healthcare promotion, right? That 5-word message, that quick tweet. From a public health perspective, there's a lot of opportunity in that as well. The problem, though, that we have is that fake news or false news travels 6 times faster than factual news. If you can come up with a sound bite that has folks arguing or has some sort of contention, that typically gets twice the amount of retweets or reposts than something that is of a happy situation, there's a reason why our news seems to be more doom and gloom than happy stories. And that's just what we're drawn to. And so I think that when it comes to making healthcare decisions, though, we do have to respect the science. You know, when I think about my wife and her 13 years of training that she did after undergraduate school, I have to believe that she knows more about whether or not I should wear a mask than me simply going on Twitter and seeing what my friends and family think.
Yeah, good point. And I want to just tag on to this topic regarding government. And it's not to get too far back into let's say, solving for pricing and that sort of thing, because I don't want to stay on that too much longer. But I just read a couple days ago, it was across the various news sites that because I think United Healthcare was now lowering their cost on hearing aids, what had been up to about $4,000 or $5,000 for a pair of hearing aids is now down to $699. And it's because the government intervened and made it an over-the-counter item, which I'm sure you're aware of. And because of that, you know, now the market conditions have changed. I'm wondering how much of that could be applied to saying that politicians are a big part of the problem, or maybe the holding back in healthcare because they're not setting strong enough laws and standards to let that transformation happen. I'd like to see what you think about that.
Oh, I certainly think that there are a number. I mean, there's a litany of examples where having a large government regulatory body come in creates substantial realized value to the end consumer. I mean, there's myriad of examples of that. And it's certainly something that I'm not against in terms of kind of setting the guardrails for these different programs. I think, though, that one of the areas that concerns me is how politicians are also influenced and where the money goes from a lobbying perspective, from political action committees all the way to just direct advisors that are sitting alongside these politicians. These politicians that come in and out of office, the career politicians, I mean, there's problems on both sides of that aisle. And also, when you have these elected officials and you actually look at their backgrounds, we have so many elected officials that couldn't even get an entry-level job at a hospital or an insurance company, and yet they're now informing some of the largest, infrastructure bills and regulations that define our market. And so I think that it is important, and it is a role that's needed. There's no question about that. With 330 million people, you certainly need a federal body to play some sort of role there. That being said, the amount of conflicted interest that also plagues that same body is something that I think all of us should scrutinize. And if you want to talk about transparency, sure, let's put up all of the hospital bills and pricings and make sure that it's consumer friendly. But we should also have a concerted effort on the same exact thing when it comes to politicians. Who are you taking your money from? Why are you voting for certain bills a certain way? Make it transparent, easy to read. Anyone who's ever downloaded a bill and tried to read through the legalese, it's difficult to even know what you're reading. Simplify that to a 3rd to 5th grade reading level, the same way we have to with our healthcare information that we send out and the bills that we send out. I think that could actually have a larger effect maybe than just asking for reform of the bad apples within the healthcare side. And maybe we can get to the political side of this as well.
Jeb, you're not bashful when discussing value-based reimbursement and the fact that let's say it's fallen short of expectations. At least in your book, you mentioned that. And what do you see as the biggest mistakes in thinking around metrics and measurements that are making value-based reimbursement more challenging to be successful?
Yeah, this is a hot topic for me. This is something I've spent a lot of time working within over the last decade. And there's a few things I'd call out. So number one, I have issue with just the general methodology of implementation. So most insurance companies that are practicing any sort of value-based reimbursement model are contracting directly with the tax ID number or TIN. The problem with that is that beneath that tax ID number sits a cost center that pays all the physicians or clinicians within that entity. And that gets down to the MPI level. Too often what we find is that at a TIN level, at the entity level, there's a value-based arrangement. But when you actually double click and look at the MPI level, there's no value-based compensation at all. In fact, it's a salary or maybe even an RVU base. And so there's a pretty large paradox there between what we're applauding in the market of hey, 90% of our payments are tied to some sort of value-based arrangement at the TIN level. And yet, if I would ask, is that the same for the compensation level? And the unfortunate answer is no. Most clinicians today are still paid on a fee-for-service RVU basis that is tied strongly to volume and not to value whatsoever. So I think that's number one. That's like the most critical thing. If you forget everything else, that's my biggest issue. The second piece of it is that we are scared to move providers into differing forms of payment, even though we know, and the literature states clearly time and time again, that not all providers are created equal. And so we have to get comfortable with how do you want to grade different providers and pay them differently. We pay differently for our services across every other sector. You pay cheaper at a fast food restaurant than you do at a fine dining restaurant, and we're all okay with it. The chef at a fine dining restaurant is a different cook or chef than the one at the fast food restaurant. We have no problem calling that out. And in fact, even a 5-year-old can kind of see the difference in that. And yet we have providers in this country that practice medicine that time and time again has poor outcomes, avoidable complications, and yet we're scared to ostracize them, call them out, or pay them differently. That's a problem, right? And we're constantly going to point to the data and the measurement as the problem child. But the fact is I think that we also have to just ease up a little bit, not be so sensitive, and just own the fact that philosophically, not every provider is created equal. And then that ties into the next point, which is the problem I have with a lot of value-based programs today is that they scratch the surface of quality, right? Paying an endocrinologist or a PCP for completing an annual eye exam for a diabetic patient or managing A1Cs. This is like paying an employee to open up their emails or answer phone calls. There are certain things that are expected of you as a provider. And I can say that because I truly believe that we are seeing more and more programs that are paying for what your Hippocratic oath is supposed to cover, not what the insurance is supposed to cover. And so I can't help but be somewhat cynical and critical about that because many providers will continue to focus on getting payments in those verticals versus moving towards outcome-based payments. And the reason why is because they don't feel like they can influence every single outcome. Attribution methodologies are one thing that certainly comes up. How is that patient attached to me when they flew down to Florida for 4 months and went and saw some other provider that was doing an echo every other day? Am I really responsible for that cost? And those are the difficult conversations that we have to solve. But what I think is we need to steer into the hard stuff and solve attribution, solve measurement of total cost of care, figure out a equitable way to grade providers and not just revert back to paying for things that in my mind are the table stakes of being a provider in this country. Not to mention the fact of if we're going to pay more than any other country, double, triple, most developed countries, we can and we should expect a higher quality, better experience from what we're paying for. I think that, again, that's okay for us to hold that expectation. So there's a few of the facts and figures that I bring up that are my issues with value-based reimbursement, not to mention the fact that we've been saying it so much over the last 10 years that I think we've bastardized the statement. And so now I almost squint and squeeze when I have to tell folks that I started my career in this value-based world because I know everyone goes, oh, that's like the 2010 version of wellness programs, right? Sounded great. Everyone bought into it. Not sure it had the effect that we all wanted and expected.
Jeb, just as a quick follow-up to that, I'd love to get your thought on the fact that we certainly see value-based care attached to primary care, but we're not seeing it attached to certainly a lot of secondary or tertiary level care, which is, as you know, quite a bit of the dollars that are in healthcare today go through those two segments. Where do you see value-based care? I know it's been tried, the bundling before, but where do you see value-based care? And do you see value-based care and reimbursement getting into the secondary and tertiary levels?
Yeah, no, absolutely. It has to. I think that we still have a very strong mission within this country around primary care. And I think the reason for that is that when you look at efficient models of care, you typically see anywhere from 7 to 12% of the dollars being spent in the primary care setting. In today's U.S. sector, the number typically goes between 3 and 6%. And so I think one of the focal points is getting more care back to the primary care provider, which outside of the home is really the lowest cost site of care. Now, that being said, specialists are not immune to this kind of evolution that we're on. And what we find is actually with the PPOs and EPOs and all those different product types that don't require you to go through a gatekeeper as a PCP, we find a lot of polychronic populations treating their specialist as if they're their primary care doctor. And so we have to move into that arena. And yes, you're right. There's bundled payments, there's total cost of care, there's professional capitated models. There's all sorts of initiatives that have been rolled out. I think that it is a giant miss to not go into that secondary or tertiary level. The only other thing I'd call out, though, is that most of the value-based programs today function on a fairly simplistic mathematical equation around shared savings. And when we use things like shared savings, that's fine when you're the primary care doctor and you're making up 5 cents on the healthcare dollar, right? So when you avoid that admission at the hospital and save $10,000, we can give $5,000 or 50% of that back to that primary care doctor. That primary care doctor never felt any change in their business model. And this is just incremental or additive funding. That being said, if you put that same hospital into that same program and say we avoided an admission, that was $10,000 that you would have received. And now in return, we're going to give you $5,000 for avoiding that admission. Although they are avoiding the costs and expenses, in a lot of ways, they're not. They still staff the providers, pay for the lights, have the ancillary staff members there, and are supposed to be keeping that entity open to the public. So there's a lot of things that are fixed costs that do not ebb and flow with the volume of the patients that are coming in. And so that economic model does not create a solvent financial situation for most hospitals. And I think that's what we need to solve for, is how do you create alternative revenue streams for providers to either keep them home or, like I said at the very beginning of this conversation, at least improve their margins so that they can justify moving into new areas as that demand destruction occurs at the inpatient setting.
You believe that many of the efforts put forth by different companies in healthcare and even entire industries to quote unquote fix healthcare is, as you wrote in the book, a massive and deceptive repositioning effort and more of a quote shtick. And in the book, you state this, I want to read this: organizations are inherently biased against potentially undermining their own profitability, even if they can see that eventually the revenue generating model they depend on is on the verge of breaking the American family bank account. So let's say that we do all the right things to transform our current system into one that is going to be cost effective. It's going to be high quality. It's going to be value driven. It's going to be sustainable. Jeb, do you see this happening without patients and healthcare companies, including doctors and nurses, having to go through a lot of financial pain and change?
I don't. I actually don't. Because I don't think that in today's world, you're going to see organizations change until they are literally forced to. We see that. I mean, most of your hospital CEOs look very similar to an NFL running back. They got about a 3 to 5 year lifespan to sit at that top. When you're talking about these strategies and these evolutionary paths, these are 5 to 10 year journeys that these health systems have to go on. And the successful ones start the journey before they even feel the pain, because they see what's changing in front of them and they play to that and they change their business model accordingly. Not to mention the fact that it's simply better for the American family for more health systems to take this more aggressive approach to becoming progressive and evolving to a more value-based future. The fact is, though, let's look at the fact of what happened during COVID-19. What did every hospital report on? Even the most noble publications report on. Patient volumes are back. Well, what does that mean? We are focused on rates and utilization. And I would go so far as to say that the 2 years that we had to fight COVID, where hospitals were feeling that day in and day out, that probably wiped away 5 to 10 years of value-based journey and evolutionary steps forward. Because most hospitals today, going through the economic climate that they're going through, they're looking for one escape valve. You know what that is? It's increasing their commercial rates. No hospital right now, at least none that I know, are going to the insurers going, could I please move into a fully capitated global budget? Could I please move into that most progressive form of value-based reimbursement that you have? No, I want a 10, 15, 20 point rate increase to protect the model that I know and that I cherish and that I trust. And so I think as we move into the future, you're going to see a very, very turbulent process for most of these health systems. And the truth of the matter is, we know that there is a better way. And so unfortunately for these folks, they're not going to be able to hide behind, oh, I hope it clears up tomorrow. I think this is the start of the end, which is we are going to have to move to this next chapter. And that as the population today, what is it, 16 or 17% of the American population is 65 or older. Just within the next 10 to 15 years, that's going to get to about 22 to 24%. As we see more folks moving on to Medicare through this recession, you'll see more folks move on to Medicaid and Obamacare. As we see younger folks come up, we're missing 500,000 working employees between the ages of 18 and 24 because they are part of the gig economy, right? Where they are going to be buying off of Obamacare when they turn 27. Those are the types of folks that I'm looking at right now saying, okay, you are going to change the game when it comes to reimbursement, and we're not going to be able to play the rate increase utilization game. It's going to become more about global budgets. It's going to become more about these value-based initiatives. And so the health systems that are taking those aggressive steps now, those are the ones that I think are going to be in a more stable position in about 5 years.
And speaking about moving forward, in your section of the book on starting over, you detail 10, quote, inescapable realities that we really have to accept on a societal level if we're going to have positive and meaningful change in the health system, specific to, improved outcomes, lower costs. And, here's my shades of gray question for you, Jeb. Since many of what you mentioned, the realities, inescapable realities, largely exist today, which of the 10 are most important to put into what I might call targets or controls in moving forward? Like, I'll give you an example. I think you say there'll always be a government role in healthcare. Well, okay, well then how much? And can we lower it? And should we be okay with the status quo? Or there's always going to be a large percentage of GDP spent on healthcare. Well, okay, but are we ever going to bring it down? Or should we bring it down? Or should we just accept it where it's at? And so I'd like to get into that with you if we could, just where you see some of those, some controls needing to happen on some of those realities.
Yeah, I think that two of the areas that I focus on a lot right now are, one, from a macro perspective, yes, do we spend 20 to 22%, I think is where we're going to be in the next few years of our GDP on healthcare? Yes. Is that wrong? Maybe. The problem is that it employs 1 in 7 Americans, has some form of employment through the American healthcare sector. And so part of me thinks about American healthcare as a jobs program. And yes, it's expensive. And I think that it's appropriate in terms of what it's doing to the average American family? Absolutely not. Do we have to come up with new funding mechanisms and operate leaner, more efficient models of care? Yes. But that being said, we have so many folks right now that are in technical colleges, community colleges, getting their bachelor's degrees, master's degrees, MPHs, MHAs, BSNs. I mean, you got a whole plethora of folks that are saying, these are the credentials I want to get. I want to serve my local community, and I want a predictable career. I'm willing to work every day for the next 30 years to create value for my local community. That's noble. Why would we not support that? We need that. And so part of me is just hesitant to say, do I think that percentage of the GDP will come down? If I had to say yes or no right now, I'd say no, I don't. I don't think it will. Does it need to grow at a slower rate? Yes, I absolutely think that needs to happen. And then the other side is decoupling the employer healthcare benefit and really allowing individuals to make choices and to shop a little bit more. This certainly needs to be looked at and controlled, because you can't reverse back to the era of underwriting where you're looking at individuals' predispositions and you're increasing the premium cost based upon factors and societal issues that they may or may not even played a role in. But regardless, even if they did play a role in it, that's not how insurance works. Insurance is a funding pool. that is meant to offset high risk with low cost, low risk. And so I think that it's important that if we do move into an environment where you decouple insurance from the employer benefit plan, then you have to make sure that we have some protections and controls in place to make sure that we don't move back to allowing folks that are already marginalized to become more marginalized by not being able to procure health insurance. But that's where I look at models like ICHRA, where you see examples of employers giving subsidies to employees and allowing them to make their own choice on the exchanges. I like that. I think that that's good. I think that we allow the employees then to make bigger decisions that are focused more on their specific needs. And then the innovation that occurs is you start seeing a lot of these point solutions that we've been looking at for the last decade. And you start to see them come in and say, look, things like CSNP actually work really well in Medicare. Could we bring that over to the commercial side of the house and allow for us to have really specific specialty insurance for very specific needs? And maybe then we can even get more aggressive when it comes to these gene therapies and things that we are all preparing for right now in terms of the high cost claimants over the next 5 to 10 years. And more aggressively go after that. And again, that also allows us to focus on personalized medicine through personalized insurance plans. So similar to how you buy your auto insurance or your car insurance, your home insurance, I think that there's probably something there to explore. And I think that decoupling it from the employer also allows employers to become more competitive, especially on a global landscape. We're putting a massive anchor on them right now by requiring them to pay both a Medicare tax as well as 3 to 4 times that Medicare rate on their own commercial rates. So again, I think that there's a number of reasons to kind of look at new ways of doing things, but also the controls that are needed in order to roll that out.
Now, Jeb, if I push back on that just a little bit, I'm talking about the decoupling from employer-based insurance back into making it all individual-based. Mm-hmm. Obviously, the cost to an individual today is significantly higher than it is for a per person, per member, than it would be for most larger companies. So, and we know that, wages have stagnated over the last, I don't know if it's 30 or 35 years now, but they've been stagnant. And that seems to be sort of the hidden trick is that, the rates go up for employers and employers keep wages largely stagnant. So I guess my question to you would be, if that decoupling happened, then would there have to be an extra piece in there where wages would, I don't know if you'd have to have government force this to happen, but wages would have to be increased so individuals could afford, the higher rates.
Yeah. So if you decouple it, the money that goes towards the individual or employee's benefits today needs to go to the employee. There's no question about that. Whether or not they use that on benefits is that decision. I think what you then move away from, though, by doing this, what you're now removing from the equation is that broker-consultant relationship with the insurers, right? And also that broker-consultant relationship with the employer. And so that HR benefit leader that went to school with that broker 30 years ago and they stay tried and true to each other, and that broker who happened to also go to school with the Blue Cross Blue Shield executive or the Humana executive or the Name That Buca or local regional payer executive, that relationship is one that in a number of states is unregulated in terms of what types of commissions or overrides or consulting fees can be paid. There's a perverse world that sits right within that. That again, there's a number of brokers. The vast plurality of them are well-natured, well-intended professionals that are impartial. But still, it shouldn't bother anyone then for me to say, open that up. Allow individuals to see right through that relationship and allow the insurance companies and providers to compete. And what we very well will find is that there are individuals that are perfectly fine with a singular health system access point in their local town. And as long as it covers all of their primary through quaternary needs, they're good to go. And they'll use a little wrap network every now and again, but they don't make the same buying decisions that an HR benefit leader or a broker uses when they say, oh, actually, no, you have an employee that lives in California, so you need an expensive wrap network because you're based out of South Carolina, and we need to make sure there's access out there. Well, what if that individual in California is also okay with having a singular narrow network that's actually far cheaper than that national wrap? There's a lot of efficiencies to be gained here. And I think that as you look at the gig economy, you look at more employees that kind of move away from traditional working relationships, you're going to see this naturally arise. Whether or not the federal government plays a role in that, I think is left for discussion. But I think that the impetus is that there's hundreds of thousands of folks that are missing from our workforce today that are off doing their own thing. And those are the folks that are going to say, I want an individual insurance package. I also just think when you look at the numbers, at least from my humble opinion, it makes financial sense to do this as well.
And I'll just add on too, and I'd love to get your thought on this just as a follow-up. We mentioned at the beginning of the show, we talked about, or you had mentioned that, there's so many leaders today that are thinking one way, but what they're speaking is another, and mostly for job security purposes. I wonder when it comes to BUCAs and BUCA brokers and that sort of thing, if you just have people in HR that are like, we could do something with a TPA and some sort of really unique thing here to bring down our costs 25, 30%. But that gets us away from the standard BUCA stuff. And I don't know if I want to put my job on the line if I go this unusual route. Let's say it doesn't work out, or employees, let's say, lose their provider they've had for years or something. How do you think about that? What do you think about that? That there might be people on the HR side that for their own job security, they just keep going with the same plans or the same BUCA type, choices year after year.
It's a really astute point that you make. And I think that it's a common sense reality that we all live within. It's human nature to pick, the common road, the one that we understand, the one with less barriers, the one with lower risk. And at the end of the day, if you have an HR leader who's being graded or monitored or measured on the cost of healthcare or the experience of the employees, not to mention the fact that it is so competitive right now for high top talent within this country, you don't want your benefit experience to be a thing that drives people away from you. So there's a number of risks. And I think that you're absolutely right. I think there's a lot of risk aversion to this selection bias here. But that being said, I'd make the argument that show me a happy customer of Comcast or Spectrum, right? Their NPS score is like less than 12. It's the same thing with health insurance companies. So I almost feel like, well, it can't get much worse. Maybe we should try something different. And if the experience is below that, well, then you found a new rock bottom.
Jeb, moving over to another subject here, what do you think of retailers such as Amazon and Walgreens and others that are now entering healthcare?
Yeah, that's a nice, big, broad question. And I do have experience working for CVS Aetna, and I had a chance to kind of see the strategy from the inside. And one thing I could tell you is that I'm a firm believer that convenience is a high qualifier when it comes to creating value within the healthcare sector. So, anytime you have something like CVS where, 80% of Americans live within whatever it is, 5 to 10 minute drive to one of their 10,000 locations. Same thing goes for Walgreens. You have a convenience factor that should be valued and respected. Now, that being said, as you think about companies like Amazon, the recent news there that they're going to be launching a curated kind of clinical point solution marketplace, I think that's really interesting because I think that they understand how to capture everyone's eyeballs and get us to look at things in different ways. And they make the ease of purchase and reviewing and assessing something that's, second to none. And so there's certainly a role for retailers. I think everyone talks about it. What people don't talk about is the negative side effect of that, right? Which is the fact of, yes, Walgreens, Amazon, Google, CVS, Apple, right? You name those big companies that have a lot of local footprint that we all know the name brand, those blue chip stocks. I guess the question for me, though, is that why have those organizations not seen the returns that they initially expected over the last 5 years, right? There's a lot of strategies that have started there and then slowly but surely been ended. And I think that it's important for us to ask why. And the reality is that healthcare is really difficult. And the more folks that you enter into the equation, the more disintermediated the experience can become, the harder it is to get information from one provider or one decision maker to the next. And so although convenience is a large factor, and I'm always going to champion anything that gets more prevention and promotion into the market, I simultaneously think about the fact that as you bring in new entry points, you have to make sure that the care journey and the experience for the individual is thoroughly understood and thought through. There's nothing worse than coming up with a wonderful point solution, a convenient point solution that at the same time doesn't connect back into the broader ether of the healthcare ecosystem. And then you end up duplicating care. The other side effect is that what are you drawing in when you are intervening with these patients, right? So I think about the phenotypes of patients that typically like to use these local retail locations. There's certainly a need for the prevention and promotion, but there's also a healthy population that's kind of like the worried well. And from an insurance perspective, what we're doing is we're allowing these folks to just kind of abuse the diagnostic nature of wanting to measure and look at everything. And each time I cough, each time I sniffle, each time I have a headache for 5 minutes, I need an intervention. And the question then becomes, are we truly driving efficacy in the interventions that we are putting forward? Or are we driving profits? And when you look at these organizations that report out to the street, you have to think about yourself of what is going to happen once they have a captive audience, once they have a patient panel size. Are they immune to the same financial pressures that other publicly traded companies have, which is you might want to do the right thing, but your shareholder comes first. And so I just always kind of keep a skeptical eye on anybody that has to put a shareholder above a patient. And that's not to say that you can't balance that and successfully deliver value, but there's always going to be a balancing act between value creation and value extraction. And I think that it's important from the consumer perspective to keep an eye on that. And then the last piece that I'd throw out is as we think about these convenient factors, as we think about the interventions and the phenotypes of patients that typically are seen in these places, the other side of it is some of the literature that we've looked at. It talks about urgent cares and how some urgent cares really are like an expensive triaging unit. And eventually you just see that patient also show up at their primary care office or at the emergency department. And really what you're left with is a double claim. And so what I think is also important is that as we see patients go into these retail care sites, that they're not simply stepping in, driving up costs, and then due to the disintermediated level of clinical information being shared, a redundant diagnostic or lab or whatever you might be having at that local retail location happening again at the provider. That would not be a win for the global system. So I think it's important. I think it's a really innovative idea to continue to push in the retail space. But I think there's a lot of slippery slopes that we need to be mindful of. And we need to call them out early and call them out loudly and not be so scared that, oh my gosh, you can't say that because it's a Walgreens or a CVS or an Apple. I think it's actually more important to say, let's finally learn from our history and try not to repeat it twice.
And very quick follow-up. Do you see Amazon in particular making a play as leveraging its 150 million plus Prime members, making a play as either its own insurer or maybe a group purchaser by using all those people in leverage?
Well, I certainly think that if you continue to see things become more individualized, absolutely. I think the problem, though, with today is that the commercial population is where the majority of revenue sits, and the decisions made around GPO-like offerings are typically made at an employer level and not at an individual level. That being said, there are certain health benefits that, I'm sure you could use a collective large group, 150 million people. That's a lot of people. That being said, why can't they convince 150 million people to go to their grocery store and buy groceries that are organic and fresh and expensive? So I also remain dubious about the ability to actually drive large masses to do things. There's a reason why 50% of Americans that have a heart attack are non-compliant with their beta blocker less than 3 months later. We are highly influenced, highly irrational individuals in this country and in this world. And so I think it's difficult to compel an individual to do something that, although it might be healthy for them, might not be in line with the broader universal forces that are at play, including our own will. But that being said, yes, Amazon certainly has a lot of incredible touch points. I guess I just haven't jumped on the Amazon bandwagon yet. just due to the fact of, everyone likes to romanticize the use cases. And me, I like to just see the facts and figures. And I'm still waiting for more folks to go to their grocery store.
For our audience, Jeb, what would be the most important thing that you would like readers of your book to take away? 3 things. Number 1, I certainly don't curse as much as you see in the book. I think it's one of those things where it's important to be authentic. And sometimes I find, having 8 older sisters and an older brother, I learned really early in my young childhood that there's authentic language that allows folks to then be freed up. And so one of the reasons why I use that language is really important, is to allow folks to just feel a little bit more comfortable, right? I'll be the loud lightning rod in the book, and I'll say some crazy things. And then all of a sudden you realize that your wild dream or expectation or crazy idea, maybe it's not that crazy. Maybe it's not that loud or wild. So that's number 1, is just kind of freeing folks to think outside of the box or above the box. Number 2, we will not get to a better future if we don't have these conversations, if we don't call things out. So a lot of times it does take 10, 20, 30 years of experience before we have the confidence to write a LinkedIn post about how we see the world. But the important point is that it's an opinion. It's how you see the world. There are things in my book that people have reached out to me and said, I don't agree. I don't think that's true. Or factually, I completely disagree. That's great. I love those conversations. That is what we need to have. And then last and finally not least, you're never too young. It's never too early to start being a change agent. And it's going to take a number of small steps to get to where we want to go. They're not going to be massive changes. And the folks that are going to change this world and change the sector that we work within are masses, thousands, maybe hundreds of thousands of people. It's not going to be one individual. So if you're sitting there and you say, I see problems, start helping to fix them. The solution is going to come from within. It is certainly not going to come from above or from anyone that's already retired and out of the game for 20 years. Jeb, thanks for being with us today. I really appreciate your time and stopping by. And if you could you let our listeners know and our viewers know where they can order your book?
Yeah, so it's on Amazon. If you got a Prime account, 150 million of you probably do. It's directly on there, so that's easy to get to. All the proceeds and profits are going to charity to help uninsured and underinsured Americans pay for their care. So it's a noble cause. So thank you for supporting that. And if you find any issues with the book, I'm also easy to find on LinkedIn. Not too many Dunkelbergers out there. So look me up, add me, write me a DM. I'm usually pretty good about responding. And I look forward to hearing from folks and hope they find some value in the book.
Thanks again, Jeb.
Appreciate it. Thank you.
Our thanks today to Jeb Dunkelberger for taking his time to chat with me today about his book, Rich and Dying, an insider calls bullshit on America's healthcare economy. For our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit Innovaccer.com. I'm Steve Ambrose, wishing you a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit Innovaccer.com.